Good afternoon, everyone. It's great to have all of you here. And today's webinar is packed with practical insights, case discussions, and evidence-based learning. So stay with us for an engaging and informative session. I'm Rashmi from marketing team, GenWorks Health. On behalf of GenWorks, we are pleased to invite you all to an exclusive panel discussion and RTM webinar hosted by GenWorks Health in collaboration with Dr. Priya Ganeshkumar, SaiNiwas Healthcare. A special note of thanks to Ms. Geetanjali, our marketing director, for facilitating this webinar, and to the entire GenWorks community for your continued support and contribution. We are truly honored to have Dr. Priya Ganeshkumar, who is the CWH Webinar Series Director, and Dr. Ananya Akshay, CWH Webinar Series Coordinator. We are very highly pleased to have our esteemed guest of honor today, Dr. Revati Janaki Raman, for our inaugural webinar. We encourage everyone to make this session interactive. Please share your thoughts or questions or feedbacks in the chat box. We'll take them up during the Q&A session towards the end. Before we begin, let me take a moment to introduce GenWorks Health. GenWorks Health, a Wipro GE invested company, is India's first health tech startup committed to accessible and affordable health care for all. For over a decade of impact across 8 care areas, our innovations reach beyond major cities, touching over 6 million lives each year. GenWorks Femtech solutions are designed to advance women's health through early detection, screening, and treatment in the areas of breast and cervical care. At GenWorks, we are bridging the healthcare gap and building a healthier India. Join us on this transformative journey. Here's a short video showcasing the GenWorks story and our impact.
GenWorks Health, a Wipro GE invested company, is India's first health tech startup dedicated to improving healthcare access, affordability, and awareness. We are impacting 6 million lives every year. Backed by a decade of commitment and excellence, we bring advanced technology beyond major cities, empowering healthcare professionals for early diagnosis and better patient care toward a healthier India. Introducing GenWorks' comprehensive Femtech solution for women's health screening and treatment, a device designed for colposcopy, therapy, and seamless patient data management. Whether you're conducting examinations, performing ablations, or managing patient information, IRIS streamlines your workflow with unmatched clarity, precision, and efficiency. With its thermal ablation capability, IRIS becomes a comprehensive screen and treat solution, all packed into a compact, portable device, introducing a unique combination of the EVA Pro digital colposcope and thermocoagulator thermocoagulation treatment of precancerous lesions, performed within a single sitting at point of care, increasing patient adherence and treatment efficacy. Introducing AI-enabled breast health screening. Easy to use detects tiny changes from 3 millimeters safe, radiation and pain-free AI enabled. Supervised by medical experts, quick results within 15 minutes. GenWorks Health, a Wipro.
I would like to welcome Dr. Ananya, our CWH coordinator and MOC for today's session. And before I hand over the session to Dr. Priya Ganesh, I would like to introduce Dr. Priya Ganesh, who is our CWH program coordinator and distinguished speaker. She is the medical director, SaiNiwas Healthcare, chain of preventive oncology centers pan-India, national convener FOGSI HPV vaccination project, executive member representing India in AOFOG Cervical Cancer Elimination Program, Chairperson Gynecologic Oncology Committee FOGSI 2021 to 24, Convenor FOGSI GCPR Prevention and Management of Cervical Cancer 2023, FOGSI colposcopy course trainer and convener, trained more than 2,000 doctors in colposcopy, master trainer for cervical cancer prevention in state government, MP J&K under NCD Ayushman Bharat project for cancer prevention. Over to Dr. Priya Ganesh to brief about CWH.
Thank you very much, Rashmi, and thank you very much all the faculties to join this CWH program. I'm sorry there has been a little bit of delay in the program, and can we have the slide put off, Rashmi? Put this slide off so that we can have a bigger this thing. Okay. So, Rashmi?
Yes, Doctor.
Yeah, thank you. So, this is the Crusaders of Women Health webinar series. So, this is a pioneering initiative. It is dedicated to empower HCPs with accurate and comprehensive information about women health. Our mission is to break down barriers and promote equitable access to latest scientific information addressing the unique challenges which is faced by women in India. Again, through expert-led discussions and interactive sessions, we are going to explore critical topics such as reproductive health, mental wellness, and cancer prevention. Again, providing actionable insights. It's not only the theory which is going to be there, it's going to be the practical tips which you are going to, which all the experts are going to share. So actionable insights will be there and support. So our goal is to inspire a movement of informed and empowered physicians, driving positive change and fostering a culture of wellness and self-care across our medical fraternity. And in this webinar series, I'm so happy that this first webinar series is being inaugurated by none other than Dr. Revati Janakiraman ma'am. And can we have Dr. Revati's CV?
Yeah, now I have unmuted. Can you hear me? Hello?
Yeah, Dr. Girija, yes. We can hear you. Yeah. So we have with us Dr. Revati Janakiraman madam, who is a vice president, who has been the vice president of FOGSI South Zone 2016, a well-distinguished faculty, President TNFOG 2023. She has been the former director of IOG Chennai, former secretary and past president of Madurai OBGYN Society, founder president of Madurai Menopause Society, zonal drive. She's been a recipient of various awards like Dr. Durusha Community Service Award, Lifetime Achievement Award, IMA Madurai, and so on and so forth. And she has also been a master trainer for PPIUCD. So welcome, Madam Revati Madam, and we would like to really hear from you. We are eager to hear from you. Over to Dr. Revati Madam. So this slide can go off and we can hear Dr. Revati Madam.
Thank you, Dr. Priya, for your kind words. Good evening, dear friends. It's indeed a great pleasure and privilege for me to be here in the first webinar, CWH webinar series of Dr. Priya Ganeshkumar. Of late, whenever we think of cancer service prevention or HPV vaccination, the first name that comes to strikes our mind is Priya Ganeshkumar. To that extent, she has worked hard on that colposcopy training, HPV vaccination, awareness training, and so many things. Really, that is amazing. And from that shell, she has broken that and entered into general OB-GYN also and started this CWH series and chosen very good topics, fetal monitoring as well as CIN. Even though we are hearing these topics frequently, when we hear it from experts like Girija Vag, Dr. Sundari, and so many others, definitely we'll be learning a lot of new points. And that Priya is able to gather a battalion of doyens in OG for this webinar really shows that her capability to coordinate with people. She is very humble and friendly with everyone. And I'm sure this webinar is going to give a lot of information as well as interesting points to every audience. And I wish this webinar series a grand success. And more than that, especially my best wishes to Priya Ganeshkumar for her success in VP election this time. Definitely she has to, and I request everyone to give her such support. And one more request also there. I think Dr. Sampath Kumari is here. Another candidate, FOGSI presidential candidate, Dr. Sampath Kumari. And my best wishes to her and request all to support her also. Thank you very much.
Thank you, madam. Indeed, a great blessings. It has started on a very great note. So thank you very much. And we will now, this program shifts to Dr. Ananya. Ananya, can you take it up from here? And we will start our academic session.
Good evening, everybody. I think we can begin our scientific session now.
Yes.
Our first session is a reverse panel discussion. So basically, it's a flip of the traditional format where a group of panelists will pose pertinent questions to our expert, who's the moderator, for better understanding of a topic. And for today's session, it is on fetal monitoring in labor, an evidence-based interpretation and clinical action. So I introduce you our moderator, Dr. Girija Wag ma'am. She's a professor and HOD at Bharatiya Vidyapeeth, Pune. And she's also the director at Primrose Wellness. She was the former Vice President FOGSI, Chairperson of Medical Disorders in Pregnancy Committee, and National Mentor for Laksha. And coming to our panelists, let me introduce Dr. Rekha Rajendra Kumar ma'am. She's gynecologist and IVF specialist, medical director at Miracle IVF and Chandana Hospital. And she's also the past president of BSOG. Dr. Chandrakala ma'am.
Can we have their CVs being showcased? Rashmi?
It's okay, yeah. Don't waste the time.
Okay.
I'll just introduce our panelists. Dr. Chandrakala ma'am, HOD, KGPG Medical Institute, Coimbatore, and she's the current president of Kovai OG Society. Dr. Ramaraju, Associate Professor, Bellary Medical College, and past president, Bellary OBG Society. Dr. Aruna ma'am, Managing Director of Snehalata Hospital, President of Anantapur Obstetrics and Gynecology Society. Professor Sampath Kumari madam, HOD, SMMCH Chennai, President of Chennai Obstetrics and Gynecology Society and Secretary of Tapisar. Dr. Umayal Murugesan ma'am, she is the Managing Director, Sri Kumaran Specialty Hospital and President of Kanjivaram Obstetrics and Gynecology Society. Dr. Amla Devi ma'am, Director of Annai Perindam Hospital, Dindigal, and she is also the President of Dindigal Obstetrics and Gynecology Society. Dr. Vichitra, Consultant at Vijay Hospital, Karur, and Dr. Prashanti, Assistant Professor, Apollo Institute of Medical Sciences. So I now request Girija madam to begin our session.
No, you're muted, Girija. Can you unmute? Yes.
Yeah. So can I have an right to share my PowerPoint presentation? Can you just give me a sharing thing?
Yes, doctor. You can share now, doctor.
Okay, thank you so much. There's somebody who's asking for admission as well. Oh, why it is going PowerPoint live? Okay. Are we able to see the PowerPoint presentation?
Yes, doctor.
No. As of
now,
as,
yes.
as-
Yes,
no.
or no?
Yes, it is seen.
We can.
We can?
Yes,
can.
yes.
Yes, Dr. Girija,
Yes,
it is
doctor.
seen.
Okay. And okay, fine. So today, at the outset, I would like to actually thank Dr. Priya Ganeshkumar for giving this wonderful screen for us. And I'm extremely apologetic for the technical hitches that we had. I think we are connecting on multiple things here. And maybe technology always takes a toll on us when we are trying to work out things in time. And I'm also grateful to the panelists for participating, Dr. Rekha, Shishai, Chandrakala. I think all of them are not going to be there. Priya?
There are few people, this thing, but there Sampath is joining, no? So you can
Yeah.
start.
So we
Yeah.
can start, and then if there are any questions which are missing, I can just take the questions and go ahead with this
Absolutely.
wonderful
Absolutely.
concept of a reverse panel. And I'm grateful because today's CTG, fetal monitoring in labor, intrapartum fetal monitoring has become extremely important because we are trying to find answers to adverse perinatal outcomes, especially stillborns and IUDs. And that has become a huge global problem at this point in time. And that is the reason why this particular, and plus our shift now for moving from C-sections to vaginal births, it has become extremely important that we are able to deal with understanding, interpreting, and there are a lot of new things which have happened in this particular way of investigating. So fetal monitoring in labor Evidence-based interpretation and clinical actions is going to be our goal. And it's very important to know that having knowledge of education is a good thing, but using it properly is the most important thing in life. And therefore, today we'll try to, through this panel, address with the experts asking me questions on physiological bases, evidence-based methods of fetal monitoring, updations in the CTG, hypoxia, and any kind of structure or action plans. And if we have permissions or times later, we may consider discussing a few cases as well. So I think I can start being short by the panelists. And I think the first question is going to come to me from Dr. Rekha.
Yeah.
Dr. Rekha, are you there? Yeah.
Yes, I'm there. I suppose this would be the question for me. First of all, let me thank Dr. Priya Ganeshkumar for executing such a wonderful program with such nice topics. Dr. Sundari Madam, Dr. Revati Janakiram Madam, namaste to all the dignitaries here, and Dr. Girija, thanks for being the moderator. I come up here with my first question to you. So it's a reverse panel. So the question from my side would be why the fetal monitoring matters. As you have already mentioned, every beat we should listen to. Every beat is very, very important. And also we must train our ears to listen to that and interpret that. Can you throw light on this? Why it is so critical for us?
So basically we have to understand, and this is something that I spoke in my introduction as well, that intrapartum hypoxia is a leading cause of stillbirths, up to 30% globally, neonatal encephalopathy, and long-term neurodevelopmental impairments. And therefore, we have to be extremely categorical about being very sensitive to hypoxia itself. That begins. Then the acidosis sets in, which is going to damage the brain. But we have to be trying to, the CTG has to, the fetal monitoring in labor has to help us to first identify that start point. And the timely detection of fetal compromise can prevent adverse outcomes, reduce unnecessary cesarean births, and improve neonatal and maternal satisfaction as well. I just want to take a break here and ask Dr. Priya and the organizers, there's continuously a window coming asking for admission. Now, who is supposed to be giving that admission? There's a window popping in. Rahat Nizam wants to admit. It's external. So is there somebody
who should not get disturbed with this? Rashmi?
I don't know. It's coming to me. Admit.
Yes, doctor.
Yeah.
So can you address Dr. Girija saying that one popping up is coming up for admission?
Yes, doctor, we'll do that.
You
So you can
Dr.
take care of that, right?
Yes,
Okay,
doctor.
fine.
Yeah.
So now I think, do we have Madam Tirupati also here in the meeting?
Male person.
Yeah. Mr. Seshai Tirupati.
He had given his, secretary, but I can take it up over here. Is the global perspective. So I really want to understand, Dr. Girija, about what is the latest guidelines which has been there. We are all a little old now and we want to know what is the latest guidelines and how do we go with the care guides.
First, when we talk of guidelines, we should also look at one very important thing that happened in our intrapartum management, and that is the WHO LCG which came up. While we were fighting the pandemic, there were two major things which were happening in obstetric care. One was the PPH care bundle, and the second one was this LCG which was being analyzed and being promoted. Now, what is this labor care guide? It is talking about replacing the traditional partogram, and there is individualized, respectful, evidence-based care, and there is intermittent auscultation for fetal monitoring, which has been encouraged. Now, this has been given a huge lot of importance, and this auscultation can be with anything. It can be with a stethoscope or with a Doppler, but what is very important that it has to be there. I'm going to be speaking about this LCG a little bit later on as we go by. And other thing which happened is NICE guidelines had mentioned about physiological interpretation over rigid categorization in 2022, which got slacked off, and in 2024, it came up with structured response protocols to whatever happened in the CTG. So you're supposed to look at the picture holistically. You're not just going to, like, today I'll give you an example. In my OPD, I had a patient who we had done antenatal because she had severe anemia priori. So I said, now she's reaching term, just 2-3 days now waiting for her delivery to happen. Let's get her NST done. That was not a CTG. and it showed a zigzag pattern. Now you are not supposed to be perturbed by it. It's fine. It is interpreted as reactive. What I just told her is that you come back in the night once or in maybe next day morning, because the daily fetal movement counts were normal. Everything else is fine currently. So we will look at it again. So whenever you are seeing these CTG patterns or NST patterns, it's very important that you categorically, analyze them. So,
Okay.
so the next thing would be why and what is understand. Like you asked me, Priya, what is basis? So one of the most important bases is that we have to understand the physiology of fetal oxygenation in brief. And what is that? We have to understand that there's an oxygen pathway which is coming from the maternal lungs going through the placenta to the fetus. Very, very easy to understand. But the fetus is also getting adapted to this, to the increased cardiac output coming from the mother, the blood flow distribution which will occur, because you have to finally, whenever the blood flow distribution goes to the baby's brain, that means, what does it mean? That it is compromised and it is trying to have a survival instinct now and trying to protect the brain. And then it is also adapting to the various anaerobic metabolisms. And especially so intrapartum, because whenever there is a labor stress, which happens is when the uterus squeezes with contraction, the placental bed also squeezes, and that causes reduction in the uteroplacental blood flow. And we have to be understanding this absolutely correctly and clearly. So whenever we are looking at the various methods of monitoring, intermittent auscultation is typically the one which is followed in low-risk women. Every 15 to 30 minutes in the first stage. Now, this is the change you are asking me, Priya. What is so this is the change. Every 5 minutes in the second stage of labor. Because second stage is more profound. It is going to have more strong contractions. There are now going to be bony pelvis and cephalic mechanics which are going to come into order, and therefore we have to be ready there. And then when would you do a continuous CTG? Do you really need to do it in all your patients? Not really. Only if you find any abnormality in your intermittent auscultation, or if you have a high-risk mother. And of course, there are other adjuncts, but which all of these adjuncts which have been proposed in the Western world are not available to our birthing rooms, such as the fetal scalp stimulation, peripheral blood smear, the fetal blood sampling, and the scan. These are not available with us, but we can definitely switch between IA and CTG and interpret it correctly.
But I have one sort of doubt, Girija, because when you said that now the thing is like at second stage, you put it up every 5 minutes. I mean, it's as good as like
after every contraction. That was what we were talking later.
Yes.
After every contraction, ideally, you should be doing an auscultation.
Correct.
Yeah. So while the patient is in second stage of labor, usually if she's under epidural, then it may take a little longer. You should know, and you should be able to differentiate between two components. There is a component of what is called as a pelvic component, which is in the beginning. And then there is something which is called as a vaginal component, especially so in a woman who is delivering for the first time, that is a primigravida. So in this situation, once you know that the patient is fully dilated and the station has started descending beyond zero, it is important that you monitor her after every contraction. Okay, because it's a very strong contraction, and then that would take. Now there is, I think we'll not waste our time in understanding what is STAN. I don't know any one of us here in the panelists are using fetal blood sampling, so we'll just give a pass to these questions today. Let's go back to understanding about the uterine contractions, as we said, because they do cause effects on the mother because of blood flow replenishment. Whenever there is increased uterine pressure, increased maternal pain, there's reduced blood flow, reduce uterine pressure, reduce maternal stress, there's going to be fetal oxygenation. And especially so when we are using synthetic oxytocin, there are stronger and frequent contractions, and there is less relaxation time, and therefore there is less replenishment time between the two contractions. And therefore, whenever we are looking at the efficacy of the oxytocin augmentation drip, to see whether it is effectively giving us contractions. One of the most important parameters that we must definitely look for is how much is the interval between two contractions. It always has to be 1 minute. It has to be minimal 1 minute because that gives the time for the replenishment of the uteroplacental blood flow. And therefore, it's essential that we have a close fetal monitoring, especially when we are using oxytocin. So I would like any of the panelists to make a comment on this particular aspect that we have discussed so far. Madam Sampath
Dr.
Kumari.
Aruna, Dr. Aruna is there with us. Dr.
I saw Dr. Ramaraju also coming in.
Dr.
and
Chandrakala, Dr. Ramaraju, Dr. Amla Devi, madam.
So exactly we
Yes, madam. We can hear you, Dr. Amla Devi, madam.
yeah we agree with Dr. Priya work because this is the standard what we are following, you know.
Yeah. So thank you, madam, for getting into agreement. So we have to understand that, yes, oxytocin is there, physiologically present, and it is causing uterine contractions. But there is a difference when you're using a synthetic oxytocin. Now, what is the difference? There is going to be, in a natural oxytocin, there is rhythmic gradual contractions. There are neurohormonal effects which crosses the blood-brain barrier. There is endorphin release, which is very important, which is a very positive hormone, as we all know. And therefore, it gives rise to a lot of emotional calm when there are natural oxytocin contractions which are coming. And there is also an adequate recovery between the surges, which helps in maintaining the fetal oxygenation. But in a synthetic oxytocin, they can be, especially if there's a continuous infusion, they can be strong, frequent contractions. There is no endorphin mediated pain relief or emotional modulation. And there is always a risk of hyperstimulation, which will reduce the uteroplacental perfusion and cause fetal distress. So I think one of the most important messages when we are using synthetic oxytocin is be very careful about not only oxytocin, but also about the fetal condition, because the fetal and the maternal modulation may go for a toss. And therefore, the question that you asked me at the beginning is always remember to begin with a minimal dose, assess the fetal basic parameters on the CTG, watch for hyperstimulation. And what is hyperstimulation? More than 5 contractions in 10 minutes or less than 60 seconds relaxation. Maternal assessment, when she's saying I'm in pain, speak to her. That's very important, because don't just say ha dukta hi hai, tumhara labor mein pain hi hone wala hai. Please understand there is no endorphin. It's going to cause problem to the baby. And the immediate action in such situations has to be to discontinue oxytocin, because finally we have to have an aim and a goal of achieving a wonderful healthy baby and a wonderful maternal experience of that particular labor achievement. And therefore, when we look at the frameworks as we were talking about, and you asked me about the change, what we are talking about in the FIGO 2024 is external monitoring first, internal only if there is a poor trace, continuous CTG, which we spoke at the beginning for high-risk mothers, and avoid routine admission of CTG for low-risk mothers, because then you will unnecessarily not over-interpret situations. And physiological interpretation is a very important question at the end of the 2024 consensus. What it mentioned was focus on fetal compensatory versus decompensatory patterns and recognize zigzag patterns, autonomic instability, and chorioamnionitis, which are the important things which you have to see when you're interpreting the CTG. So when we look at these baseline features, normal is 110 by 160 beats per minute. Variability normal is 5 to 25 beats per minute. Reduced is a concern. Accelerations are always reassuring. And decelerations, which are early, are benign. Which are variable are because of cord compression, and which are late tell us that there is a uteroplacental insufficiency. And especially when there is a severe fetal anemia or hypoxia, there can be sinusoidal patterns, and these are definitely ominous. Especially now, Priya, we are doing a lot of intrauterine transfusions, especially in Rh negative mothers. And when we have finished with that transfusion, we are waiting now when to deliver, what next to happen. We have to depend on these NSTs and CTGs to guide us. What best can we do for the baby? And those anemias can be picked up. Anemia can also be acute because of an abruption. It can be because of severe uteroplacental insufficiency, and this recognition is important. So I would urge the panelists to ask me the next question.
Yes, Amla ma'am.
Yes.
Dr. Ramaraju, Dr. Aruna.
Any question?
No,
Can we go
no
with that?
questions. No
Okay,
questions.
can
No,
I continue?
So
Yeah.
far it
Yes,
is very
you
clear
can,
and
yes.
understandable. So no
Okay.
questions.
Very
So
clear.
now we are now coming to one case situation from where I want to just tell you how tachycardia is very important. That was going to be our next plan on the panel. So we have Mrs. A, a 28-year-old primary gravida at 39 weeks in spontaneous labor. There are no comorbidities, absolutely a low-risk pregnancy. Intermittent auscultation has been normal, and she's been progressing well in active phase of labor. And then there is a sudden change. She complains of dizziness. CTG is therefore initiated, and it shows baseline 170 beats per minute, reduced variability, and late decelerations. You can see that there are three very, very important things that we are seeing. And where has this happened? This has happened in active phase. So what are the four important parameters here? One, the phase of labor. Two, that she has tachycardia. Three, she has reduced variability. And four, there are late decels. Now, we all saw that these are all going out of the physiological limits. So therefore, whenever we are considering tachycardia on a CTG, whenever the fetal heart rate is more than 160 beats per minute, it's tachycardia. Less than 110 would be bradycardia. Now the question comes, why did this mother have tachycardia? So we are supposed to look at the maternal factors such as chorioamnionitis, dehydration, hyperthyroidism, medications if she's taking any, fetal hypoxia, fetal infection, fetal anemia, or whether there has been a use of a synthetic oxytocin giving rise to hyperstimulation, or whether there is epidural, where sometimes due to maternal hypotension, there can be compensatory tachycardia. So these also have to be looked into. And clinically, we have to be understanding that tachycardia alone is not always pathological. So if you are only looking at tachycardia, don't worry. Look at the maternal pulse. Maybe something is transient. But here in our patient, we had reduced variability. And we also had late decelerations, which are suggesting evolving fetal hypoxia, which needs us to do an urgent action. So we all know that physiologically increase in sympathetic activity, catecholamine surge, and reduced parasympathetic maturity may give rise to tachycardia in these patients. And this we have experienced even in our preterm babies, where the parasympathetic autonomic system is not very mature. And in these preterm babies, if you are looking at a CTG trace like this, you should not be worried because they are not going to be having a good variability. They may not have the correct fetal heart rate, and the typical more than 15 beats peak will not be present. You will find that before 32 weeks, even if there's an acceleration of 10 beats or more, is adequate for you to tell us and give us an answer. And therefore, whenever we are looking at understanding loss of variability, is it infection, decelerations we had, is this an occult cord compression? And many times we are seeing that even the cord gets compressed between the body of the baby and the uterine muscle. And this can happen because, especially in larger babies, is that happening? Or we should also consider the gestational age when we are interpreting. Now, we had a patient who was at term, and a non-reactive test following an earlier reactive result is highly suspicious. So as I told you, tachycardia is not essentially hypoxia, but variability absence and decelerations are definitely concerning. And bradycardia is always ominous. And if it is very less, then you have to consider whether the baby is having an cardiomyopathy induced by hypoxia, and this has to be our understanding. Now, variabilities can be of various varieties. And therefore, whenever you have a variability, that means it is leaving the baseline many times and quite often. You have to consider what kind of a pattern it is. Now, reduced variability means that the ups and downs are less than 5 beats per minute for more than 50 minutes in the absence of decelerations, or more than 30 minutes with decelerations. So this is the right interpretation. And this tells us that there is an autonomic system imbalance. And we have to remember that autonomic system is very sensitive to hypoxia. Fetal sleep cycles, there can be maternal medications and fetal hypoxia and acidosis. So all these have to be taken into account. And then our patient also had decelerations, which refers to the transient drop, may indicate fetal response to stress, especially hypoxia or cord compression. And you have to look at its onset, and then you'll define it whether it's late, early, or variable. And if you remember, our baby had late decelerations. So you're not just going to ward it off कि पहले तो सब normal था, अभी तो prime ही है, उसको कुछ नहीं हो सकता. Go and do a pervaginal examination and see what's happening. There can be some sort of an obstruction. There can be something which will give you a clue on a pervaginal examination, and this has to be seen. So based on which type of decelerations they are, if it's early, it is because of head compression, which is usually benign and physiological. We know in the second stage of labor, when the head is negotiating station 0 and onwards, head compression can cause some amount of vagal stimulation, giving rise to cardia, but it should not be less than 110. Variable can be abrupt onset, may be benign, because with the baby's movement, sometimes the cord compression may move. But if it is late, that means it's uteroplacental insufficiency. If it is prolonged, it means hypoxia, cord prolapse, hypotension, requires urgent evaluation. And if it's sinusoidal, it means it's ominous with a severe fetal anemia. And these are the various ways in which we interpret them. And we therefore have to look at how these things are being taken into. Now, if such a thing has happened in our labor, it's always important that a senior is involved or somebody else is involved as well if you are monitoring it primarily, and take a second opinion. And initial assessment, maternal vitals, position, contraction pattern is important. Conservative measures such as left lateral position, IV fluids, stop oxytocin, tocolysis if needed. Sometimes, you remember we used to have this in the past. Bricanyl cough syrup used to be given to the mother. It will cause some amount of tocolysis. And so reassessment of CTG, improvement, escalate to senior review, consider. Now, these are some things which we don't do. Usually, we consider expediting delivery. So these are the typical CTG traces, as you can see here. This is the fetal heart rate, which is showing a good variability and an acceleration as well. You can see that the mother is able to perceive the baby's movements, and there are fetal movements also which are recorded by the machine. And you can see that the uterine contraction, this is just an admission test which is looking perfectly normal, and there doesn't seem to be any abnormality. So assessment of the antenatal maternal problems, fetal problems, and intrapartum risk factors are extremely important, especially epidural oxytocin, the interventions that we do, or if the patient is having vaginal bleeding, is it a sign of placental separation, maternal pyrexia, or any fresh meconium stain liquor. So whenever we are looking at every kind of a challenge in the baby's heartbeat, one has to remember that there is definitely a sequence which happens, because once you are able to clinch the hypoxia, you'll be able to prevent the further respiratory and the metabolic acidosis. And many times that bradys which come in may be a sign that the baby's heart itself is failing. And therefore, it's very important that we are early in our actions. So these are those typical sinusoidal patterns that I've been speaking about. You can see this is a prolonged deceleration following a uterine rupture, Very important when you are doing a TOLAC, that is trial of labor after C-section. You have to keep a watch on the decelerations correctly. The first sign of fetal distress in TOLAC, the standard of care is look at tachycardia and variables. If there is an variable deceleration, or if there is a tachycardia, that means the intrauterine pressure has changed. Probably the scar is thinning out or giving way, and therefore you have to be careful. Prolonged deceleration can also be a sign of abruption. So one has to be looking at this carefully. Likewise, you can see here, everything seemed to be a little better. There was an acceleration, and then there is a sudden event, a drop here has happened. This may be a placental event. Likewise, you can see, oh my goodness, the CTG is completely normal here in response to wonderful uterine contractions. And then you can see, oh my goodness, it's completely gone down. So these decelerations can be sign of placental abruption. And many times this can also be seen in a patient of eclampsia. So this can be transient. Don't get carried away. That can be just temporary to maternal hypoxia, and it may come back again. Why am I saying so? Because sometimes when you see such a change on the CTG, there is an immediate action to take the mother into for a C-section. Please remember, you can oxygenate her, stabilize her, let that CTG come back normal. Many times it would come back. Of course, this is too ominous and bad. This also is bad. But we have to look at it correctly and then understand why. Because placental insufficiency, umbilical cord occlusion will give rise to fetal cellular hypoxia. And if it is acute, there can be cell enzyme dysfunction giving rise to all these changes that we are seeing here. If it is prolonged, that means it is metabolic acidosis, and there can be shortly cell death, and you will have a baby which is really born very, very sick and uncompromised. So we all should be very careful whenever we are looking at patients coming into labor. Go back and look at their priori risks, which you may have assessed during their antenatal period, to interpret what changes you are seeing correctly in this patient. Now you can see here that this is Mrs. JT. She is 33 years old, primigravida with severe acidity, anemia, which was corrected. And she has come now for the admission test, which you can see is perfectly normal. So this gives us an impetus. Okay, fine. She has priori risks. All seems to be fine. This patient can go in for intermittent auscultation. Another patient here, GDM on MNT diet controlled, and she is also hypothyroid. Admission test is showing nice study. You can see that there is some tachycardia here. Just keep a monitor on the mother's heartbeat, whether she is having tachycardia as well. Otherwise, if you look at the baseline variability, if you can look at the accelerations, you can see there are no decelerations. You are happy that this is a wonderful admission test. Now you can see another patient here, again showing a perfectly normal study at the outset of labor. Now this is a patient who had a normal blood pressure. She was already on labetalol. So the question comes, is labetalol going to cause any change in variability? You can see that it hasn't caused any change in variability. You are also seeing that she was a patient of gestational hypertension, hypothyroidism, GDM, and then she also had IHCP where her bile acids got controlled. And this is now a patient who we will properly keep her on CTG and then continue, taking care of her. What you are seeing here is her CGM, which is a continuous sugar monitoring, and you can see that it was well in range, and she was on a CGM, everything going fine. And this patient, through a continuous CTG monitoring, you could see that we were able to deliver this baby vaginally. A good, nice 3.2 kg baby was delivered of this mother, which is very insistent, despite so many priori risks, because we were carefully monitoring her. Now you can see here Mrs. S, 34 years, G2P1 C-section, a previous C-section with oligohydramnios, 36 weeks plus 6 days, has come for regular checkup. And this is just her NST which has been done. And what do you do next? Maybe you could just change a position, give a hydration, and now you can see the NST has improvised. So this NST cannot be an indication for taking her up for a C-section immediately. And I have loads of cases which we have delivered despite having a very poor AFI, but the assuring factor has been that the color Dopplers are normal. So whenever this patient had come, you just give them an assurance. Maybe we also gave her antenatal steroids that time because the guidelines were saying that if you're going to need to deliver at 38 weeks, you better give them. Now we have changed those guidelines as well. And we ordered her to come for a scan at 38 weeks. Another patient, you can see that these are absolutely normal accelerations and there are no decelerations. You have to be very careful when you're calling it as a baseline. So this would be our baseline in the middle. And then you will say, no, this is not a deceleration and this is not an, and these are good accelerations. But oh, lo and behold, what are you seeing here? This is a woman, 35 weeks plus 1 day, COVID, dengue, prom for more than 72 hours, questionable. We don't know really, but she's saying so. And then you can see she had AFI1, bad decelerations. Now this patient, we are definitely going to take her for a cesarean birth and not going to take her for a delivery. Another patient presenting with this kind of, she had an insomnia disorder, severe hypertension, not preeclampsia, but gestational hypertension, IVF conceived at 32 to 33 weeks of gestation. This patient with rescue with magnesium sulfate, because I give magnesium sulfate up to 34 weeks and antenatal steroids, we took her for a cesarean birth. So we have to be very, very careful as to what are we looking at. And this was during COVID. So we did her RT-PCR and then delivered her. So another patient with a controlled blood pressure, premature baby, please interpret correctly. This is not cause of variability, but this is not normal heart rate as well, because this is just a 32 weeks baby. So this baby definitely has some problem which has to be looked into and accordingly interpreted. Another patient, 37 weeks with 2 days, single live intrauterine pregnancy of 35 weeks, 2 days, expected fetal weight, you can see all seems to be fine. But she has a scar thickness of 3.2 mm. She was admitted for pain and then safe confinement after DM control was what was planned. She was diagnosed as an over-diabetes at 12 weeks itself, and OGCT was 224, and she was put on insulin as well as metformin combination. Now, this is her NST on admission. Now, this definitely is a worrisome NST because then this is a diabetic mother, and we have to be careful. And then this patient, we decided to take her for an emergency LSAS in view of this bad NST, and you can see whatever you're seeing here. A completely thinned out scar. There was no chance of she, and this if she would have gone into labor, definitely would have landed in a hypoxic baby. Then sometimes you will have patients like this, and when we took her out, we found that there were even loops of cord around the baby's neck. Do you mean that all loops of cord around the baby's neck will not deliver vaginally? Of course not. No. Do deliver vaginally and beautifully. So one has to take cognizance of every kind of a presentation that comes to you. You can see here another CTG which is going on. There is a uterine contraction and there is a late deceleration. And then when we decided to look at this late deceleration and take her up for C-section, everything else was normal. She was just 2 centimeters dilated. What did we find? That the entire cord was around not only the baby's neck, but also around the baby's body. And you can see that there is a never-ending cord which is being removed around the neck, and probably it was a wise decision that we took where we could take out the baby. And this is what I was trying to do, that it is not so. This is send this video to me to see. Madam, we delivered one with 3 loops of cord around the neck. So aisa bhi kuch nahi hai. CTG was constantly normal in this woman, so everything can be fine. So whenever you're looking at these late decelerations, one has to be careful, and one has to remember that variable decelerations which we were talking of are because of the cord compression. And if this cord compression is in a fetal growth restricted baby, it may not be taken well because then you will not have that compensatory acceleration and oxygenation coming by. and therefore your priority risks are extremely important in these patients. So you can see that this is a patient who is showing a little changed NST. The moment you gave her lateral position and all, everything seemed to be improvising. So I'll try to quickly move. This is the patient which I was trying to tell you. This is a woman who has thrown a convulsion. And when she has thrown a convulsion, you can see that there is a deceleration, and therefore one has to be careful that after stabilization, C-section was done, there was MSL, and this baby came out well. And you can see that there also was a
Abduction.
separation, absolutely. So this is a sign again of a placental abruption. You can see that this is a severe hypertensive mother who has presented with preeclampsia in labor, and there is a complete drop in the fetal heart rate, and you can see idiosyncratic uterine contraction showing that this is placental abruption. Another patient who had oligohydramnios, nearly anhydramnios, and you can see the decelerations here and completely. So we had to manage her first with blood and FFP. There's a huge RP clot, and then she had to deliver by a C-section. Another patient throwing up, and you can see that this is drop in the CTG. It is going to be transient. Be careful. Just 2 slides more, if you allow me, Priya.
Yes, yes, please go ahead. It's very nice.
So what we are talking of is now the new things that you are asking me. There's something called as a quickly. Now, what are these quicklies? These are decelerations that have an abrupt drop from the baseline, reaching the nadir within 30 seconds from the onset of deceleration and demonstrating a quick recovery to the baseline, which may be termed as a quickly. Now, these are believed to be due to the compression of the umbilical cord and resultant transient hypoxemia, and are not due to hypoxia and or acidosis. So it's just hypoxemia. And the intervening baseline and variability should be therefore assessed. बीच-बीच में का देखो कैसे दिख रहा है, to determine the oxygenation of the central organs, and these are associated with an increase in the baseline heart, maybe tachycardia because of catecholamine surge, increase, and then changes in the maternal position and or reducing the rate of oxytocin infusion usually helps relieve these quicklies. So you have to be looking at the intermittent trace to be able to guide you correctly. So any deceleration which has gradual drop from the baseline and then recovers slowly to the baseline, even after the cessation of the uterine contraction, may be called as the tardy deceleration. Now, these are due to uteroplacental insufficiency and may be associated with acidosis, and if they are associated with a reduced baseline variability, you have to be careful. ये देखो variability अच्छा नहीं है यहाँ और बहुत lazy curve है. So these tardy ones are often due to structural damage to the placenta, such as infarction, thrombosis, or cannot be reversed by changes in the maternal position or administration. So looking at the stage of labor, take your call and deliver her. Now, loss of beat-to-beat variability, as you can see here, with long-standing oligohydramnios is not a good sign. It's always better because she had a CPR-MC of less than 1. So that is a CPR ratio we know, which is a ratio between the middle cerebral artery PI and the umbilical artery PI, and it was less than 1. So priority risk was not happy. Take her for a C-section and you will be able to salvage this baby. And this is the zigzag pattern, which I was talking about, where the amplitude changes. Can you see? You're not able to, so here's the baseline. And this is the zigzag around it. And look at the uterine activity. What does it tell us? It indicates autonomic instability, often a sign of a developing hypoxia, and is associated with adverse outcomes like low Apgar, cord blood acidosis, and increased neonatal unit admission. And if it is observed, especially during the second stage of labor, immediate interventions like stopping the oxytocin, infusion of maternal and maternal pushing may be necessary to improve the fetal oxygenation. So you have to be looking at these depending on the stage of labor, take a call. It can be a beginning of a fetal hypoxia. So how do we get more healthy babies and fewer C-sections is what is the purpose of all these CTG. so that you don't do unnecessary C-sections. At the same time, you do rational interventions and do not overinterpret or underinterpret your CTG tracings. I'm sorry for the technical glitch, and I'm sorry that I could not make the panelists participate, but I think we can open the window to them, Priya.
Yes, yes. And yeah, I mean, absolutely beautiful. I mean, it has been a thorough walk through the CTG and making all of us understand truly how to take it up, because we are doing this day in and day out. But there are certain, many times it happens that might be we are, as you said, Girija, one word which really struck. Somewhere you see a deceleration, somewhere you see a thing, and then suddenly you panic and go back and try to take up for C-section. And when we were in our med school at that time, also when it was just introduced some 30 years back, this machine had come up, and our teachers used to tell it is actually for C-section sort of. It's you're prone to take for more C-section if you have a CTG onto it, but also we are also salving so many children. We just can't, we don't want our child to go into a PICU or a NICU and then give not a good this thing outcome. Delivery outcome has to be good fetus and a good mother. Even today I had one lady who has got a amniotic fluid is very low index, and she's almost now 36 weeks. I did her NTG today. I mean, I was just trying to see any deceleration is there. I was telling her nothing to worry. See, your this thing is very good. Yeah, there is no problem, and there is no severe acceleration or no severe deceleration. So you just have to wait. So this type of confidence which when an OB/GYN gets, an obstetrician gets, it's always good that we should wait. There's no need to hurry to take her up for a C-section. This absolutely super. Girija, I'm so happy that you have really covered everything. Our panelists are there. You can, Dr. Aruna, Dr. Rekha, Dr. Ramaraju. You all have been doing, you all are great obstetricians on your own, doing a lot of deliveries. So do you have any experience to share in this topic? I know there have been little glitches.
Yeah, I saw Dr. Umayal. I saw Madam Sampath Kumari. I wanted to say hi to Madam Sampath Kumari. Amla Devi Madam is there. Madam.
Dr. Sampath, because I'm unable to see everyone.
Yeah, this is Dr. Aruna from Anantapur.
Yeah.
Yeah. Sometimes you see that flat line in the CTG, and sometimes it will be Meconstein like, and sometimes it will be okay. Then how long we have to wait? How long we can wait?
See, if you are seeing a flat line on the CTG, first and foremost, look at which stage of labor she is. If she is in a latent phase of labor and in the absence of uterine contractions, you are still getting a fat line, there means there is a problem, and you can consider doing an ultrasound and looking at the color Dopplers. So that is one. Secondly, is this baby mature or premature, or are there any medications given to the mother? Sometimes labetalol, alpha-methyl dopa, and even nifedipine can cause a flat line. Sometimes if the mother has recently been given magnesium sulfate or a dexa dose, immediately there can be a flat line. So look at all these contexts and put the mother in the left lateral position and give her oxygenation. Now, if she is intrapartum and that time you are seeing the flat line in presence of the uterine contractions, then try to find out which stage of labor she is again. If it's an advanced, maybe changing the maternal position, oxygenation of the mother, hydration may make changes. So, and where is the flat line? Is it a tachy, brady? What is the rate of the fetal heart? This has to be taken into account to make interpretation. And so therefore, just looking at the flat line, you will not immediately, but look at the priori risk, look at the ongoing risk, look at the stage, gestation age, and then take your decision.
Yeah, thank you.
Then with a loose connection between the probe, as simple as that.
Yeah, yeah.
So
early decelerations with less than 110 beat per minute. Can we wait? Early December.
Again, look at the maternal pulse and then decide,
Yeah.
madam.
Yeah.
All and if the head is probably in the pelvis, it's a physiological brady which is occurring. 110 fetal beats per minute is acceptable for that. I have also had an experience of babies having brady from the beginning. So the babies may have a bundle branch Brock as well. And if you have such kind of a record in the priori, then that you should take cognizance to as well.
Tachycardia more than 160. Is it okay to wait?
So I did mention that only tachycardia is not a sign of hypoxia or hypoxemia. It is just a sympathetic response to something not going right. So it may be that the beginning of a cord compression, maybe maternal position change, hydration can help. Or if it is a patient of TOLAC, where you are giving trial of labor after a previous C-section, then keep a watch on her. Because there, maybe it's a stretching of the scar or thinning of the scar, which can also give rise to these problems. But only tachycardia, maternal pulse is the first thing that you should also look at, and what medicine she is taking.
Yeah. Yeah, nice. Thank you, madam.
Ma'am, there's a question here regarding the role of AI in electronic fetal monitoring, and can it be used in telemedicine?
Of course, it can be used. Now, see, telemedicine and AI are two different things. Let's look at telemedicine. I'll give you an example. During COVID, there were many patients who were delivering everywhere. And I was sitting in Bharati Vidyapeeth, and I have had connections with all our medical officers around Pune district. And they found that we can speak to madam, and so telemedicine can be of any kind. So they can send you a record of the CTG and help you interpret them. Also be telemedicine. So many of us are doing this. I am doing it on a daily basis, not only my students, but medical officers from government. So many colleagues, they will send pictures. So that can also be telemedicine. But AI, yes, AI definitely is going to make a lot of change. What change it will make is sometimes if you are able to integrate all these testing and then make an analysis, and there's a lot of work which is going on everywhere through AI, so that you are able to correctly make an interpretation. Now, what is happening currently? We are looking at a tracing and we are making our own individual interpretations. But you may get AI programs wherein you just put in that tracing and you get your answers. That this is going to happen, that is, ऐसे भी अभी भी तुमको chat GPT वगैरह से सब मिल रहा है answers, but they may not be correct. You have to remember that AI in the current thing, which is not specially designed for your needs, and if it is a generalistic AI that you're using like a chat GPT, that can give you wrong interpretation sometimes. It can also hallucinate. Remember, AI hallucinate. But definitely, even for Priya, like we have a AI program in Priya. उसको एक पूछो वो सब बता देगी अपने को, लेकिन एक शादी गिरिजा को कॉल्पोस्कोपी इंटरप्रेट करना है, तो अभी उसके पास प्रिया है, लेकिन I can just put it in an AI program and it will give my answer. This can definitely happen.
Correct. So this actually, if you have, I mean, I'm seeing this in the broader perspective as the rural healthcare and all that, and where,
oh my goodness, what a help it will be. Absolutely.
it will be like a real havoc.
It will make a whole lot of difference to things.
Correct.
But then we will have to have the courage to sit there and monitor. As Priya, you and I belong to the same generation.
Correct.
What have we learned? Be by your patient and nothing will go wrong in labor.
Very true.
This is my experience.
Absolutely true. And we used to sit with the CTG, and in those days used to be the CTG days. It had just come up in the whole thing. And sitting there with one hour, half an hour, looking at it and understanding CTG was the biggest thing, which those days was a very nice days.
Our units in Sassoon Hospital had competitions. Who will have the least C-section rates? Even that time when I was doing my residency, वहाँ तो C-section section बढ़ गया, ये बात भी नहीं आई थी. And now today also in my unit in Bharati, we are very proud of delivering even one AFI babies healthily. You know?
Oh wow.
Yeah.
Lovely, lovely. Great. So I think this has been a really an awesome lecture and an awesome beginning. I can't ask anything more. Truly, thank you very much, Girija. It's absolutely awesome. I don't have words to actually say because every aspect you have sort of revised every aspect, and all the more you have also put a lot of understanding on the newer things which has come up, newer small things which have really changed what we used to do and what has come up as a newer thing. That's exactly what CWH webinars are looking in for. And thank you really very much, Girija, to be with us.
I must, before I close my window, I must say thank you to all my patients for trusting me, one, and two, my student. Now, this particular videos which I showed you some sonographies and oligohydramnios and eclampsia. This is my student, my very first MS student who is practicing in Malegaon in a Mufassil place. He uses CTG for each and every patient. And that vaginal birth with a loop of cord around the neck and everything was from him. He said, "Madam, आप use करो because आप बहुत ज़्यादा भाषण देते हो. You can use all these my material for that." So I'm extremely grateful to him.
And I saw you holding the baby with the 3 loops of cord. So it was you who was delivering.
He was delivering it. He has sent me the video.
Is it? Wonderful.
Dr.
Thank you, Dr.
Girija,
Girija.
Dr. Girija, thank you so much. The panel was very nice. Your presentation was fantastic, especially for each situation you put a graph. Like it was very practical for us to understand. This means this, this means this. So it was very explicit and very sure we'll take more knowledge and further reduce our section rates. Thank you.
Thank you so much. Thanks again.
Lovely, lovely.
A big thank you to our moderator and the panelists who joined in for such an insightful and enriching session. So now we can move on to our second session. It's a case discussion on CIN management. Let's call in our experts. Dr. Priya Ganeshkumar ma'am, the backbone of this series, which is happening thanks to her initiative and enthusiasm. She is renowned in the field of preventive gynae-onco and is an IFCPC and FOGSI colposcopy course trainer. Dr. Bharti Rajshekhar ma'am, she is chairperson FOGSI perinatology committee and immediate past president Kasoga. Dr. Sundari ma'am, she is retired professor at MS Ramaya Medical College and consultant gynecologist at Ramaya Hospital with a keen interest in preventive oncology and teaching. And Dr. Vidya Tobi ma'am, she is ex-HOD Alamin Medical College, Vice President FOGSI 2025 and past President Kasoga 2023. Over to Priya Ganeshkumar ma'am for proceeding with the session.
Dr. Bharti is unable to open her camera. Kindly please help her, Rashmi.
Yes, doctor, we are on it.
Yeah, please. So after this fantastic, intriguing session 1, which we had, now we are going on to one case-based discussion, and we have with us all the wonderful, the experts in this field. And the purpose of bringing this case-based make only one case. We're going to talk about it. We're going to talk about the common practices which is happening and which we really want somehow to, we've been hitting our heads time and again to understand what should we do. It's all very, very common case. Nothing very important, very major case. Every gynecologist has this type of cases. And in our practice, almost 70% of our cases are white discharge leukorrhea. So Dr. Sundari madam is there with us, Dr. Bharti is there with us, Dr. Vidya is there, and we will be taking insights from our experts. So I'll just talk about this case quickly. That it's a 42-year-old female. She comes with a white discharge. It's non-foul smelling. It's no pruritus. There's off and on pruritus, and that's it. No dyspareunia, nothing. But she is having a white discharge. She has gone to various doctors for it. Many doctors have given pessaries, and she's taken many of the, oral tablets and vaginal pessaries and everything. But her menstrual history has been regular and normal. She's got 2 FTNDs. There has been no abortions and nothing. So I want to have our now panelists, like our experts. Sundari madam, this type of cases on and off we are getting. What do you think, ma'am, should be our way of approach? Sundari madam? not able to hear you, ma'am. Your mic is off, I think.
She has to unmute.
You have to unmute, ma'am.
No, am I
Yes,
audible
ma'am.
now?
Yes, ma'am. Now
Sorry,
we can hear.
sorry.
You.
Okay.
Yes.
Okay, that is a screening has to be done. Okay. For cervical cancer screening, we have to do 42 years. I don't know whether she had screening. That was not mentioned in that. She has
There
been
was no
only treated
screening
for.
done prior, ma'am. She just entered into the clinic and that's it.
Okay, she has never had a screening, so it's obvious that we need to do a screening. Now here, what is if her affordability is there, we do co-testing right away. If she is not affordable, we do a pap liquid-based cytology or even a conventional pap smear is also okay. We are worried about high-grade lesions. For that, conventional or a liquid-based is equal sensitivity and specificity. Whatever is available, we have to do that. And then we go further.
Yeah. So in this case, madam, I think I just stop sharing my screen.
Yeah, two devices.
So here we have now. Here we did her. She is little affordable, and we got her HPV done. And this was her HPV 129.8 positive, and genotype was non-1618 positive.
There is echoing.
Dr. Priya, I think two systems are open.
Two systems have been open, Priya. Your voice is recurring.
Yeah, I saw that. But I don't know. It's my one system only. So, madam, with this type of, oh no, this is, yeah. Just a minute. So, what do I do? So we can actually discuss because my voice is echoing and there is certain problem with this. So quickly, I'll just show the case and then I can stop the this thing recording, the thing, and then we can just talk. So this was what had happened was LBC came up to be HSIL. We'll just take up this case and quickly then I stop and then we can have a proper discussion. This was her colposcopy because of the HSIL and because of the genotyping non-1618 and PAP being HSIL. And a colposcopy was done. I'm going to, Madam Sundari, Madam and Bharti and everyone, we have seen this case. Because of my voice getting echoed, I'm just now going to quickly show this colposcopy. And then we are going to discuss on how these type of cases can be easily missed out. So here was a case where there is a acetovite area. Punch has been taken, which is LCIL, CIN1. But her sweeting out over here has been 1 + 1 + 1 + 2 + 1. That is an endocervical lesion. And sweet scoring is very important for us to make us understand the subject well. I brought this case purposely because many a times these lesions are missed out on our colposcopy. And having the sweet 6 makes us understand that this is a high-grade lesion. And so we have to be more categoric on understanding. So when I did a biopsy, it came up as CIN1, which was discordant to what our colposcopic finding was. Whenever there is such thing, then I went ahead doing a LETS. And I got this thing of CIN2, which was again a concordance with the PAP and sweet scoring. And now with this, I'm going to stop this and we are going to have a proper discussion so that there's no echoing now. Okay. But still, I think, do we have any, are we having this echoing coming up? Still?
Yes. It's still echoing. Yeah, it's still echoing.
Okay, so Sundari Madam, Dr. Bharti, your expert opinion on this? Sundari Madam, Dr. Bharti, how do we have to take up these cases? How are we planning to take these cases? It is for the general gynecologist, Madam. Yeah.
Doctor, can you unmute yourself?
You have to unmute, ma'am.
Hello?
Yes.
Hello? Rashmi,
Yes,
all
doctor.
the time it's getting muted. I don't know why. I'm not muting it, but it's automatically getting muted.
You can go ahead, doctor.
Yes. There is
There
echoing
is
for
again
everybody, I think.
there is echoing, no? Okay.
No, ma'am.
Yes.
Okay. About this particular case, you want me to talk about, is
And
it?
also for generally too, for the doctors, we really want to give them a good message, ma'am. How to go about with such type of cases which is coming up.
That means when there is a discordancy, what to do, is it?
Yes.
See, you have got a colposcopy done for her and the pap smear. Pap smear is HSIL. Colposcopy is low grade lesion. It looks like colposcopy biopsy. That's the time when you have this, even though transformation zone is type 1, you have to do endocervical curettage first. Okay, Priya. So when we do endocervical curettage and the lesion maybe, especially she's 45 years, maybe it is a transformation zone. I mean, type of transformation, maybe type 2, it could have been also. I don't know what is the type of
Here
transformation.
the transformation zone was
colposcopy.
type 3.
Type
Completely it
3,
had gone inside.
definitely,
Yeah.
then you have to go for an endocervical curettage.
Absolutely.
That would have given you the positivity, I mean, correlating with your HSIL. So it's on the ectocervix, have done it is CIN1. But when the type 3 transformation zone, compulsorily we have to, even we may not do ectocervical biopsy because it's no lesion is there or a very minute. You think that it's a sweet score is something less. But you said here the sweet score also is 6 or 7 on
Is
the
6.
ectocervix also. That means
Yes.
it's extending lesion into the canal. So you have to do along with that ECC. That will tell us the discordancy or cordancy, you can get it done. Even with that, there is a discordancy. Always we are worried about the, even in one report when it gives a higher grade lesion, so we can't neglect it.
Absolutely.
Provided your cytologist is very good, because the cytology can be HSIL, LSIL. I have been seeing in my practice. It will come as they will give us HSIL, and when I go in and do everything in colposcopy, there will be nothing. You follow them up, they are okay. And after some time you repeat, it will come in another lab, or you send the same slide to other expert whom you believe, it comes as LSI. This is happening to me. So that is other thing you have to think of when cytology is being an objective type of reporting. Each cytologist will report in a different way. So that also you have to keep up before jumping into a procedure like a leap or a cone or something. That's the way I do it.
Yeah. So Dr. Bharti, you've been doing lot of screening. I know in your area, and you've been very active with vaccinations and screening and this topic. You would have also seen such type of cases, and these are the cases which the normal gynecologist also sees. And many times in our practice, we are very busy with our other factors that we do miss out many things. We don't go ponder into taking up an HPV. Now here her HPV was with hybrid capture. Now the hybrid capture had shown a very high figure of 221. Now that means this RLU, when to make you all understand what hybrid capture it is and what genotype is and what HPV is for that matter, how an HPV test has to be taken up. An HPV test is, as WHO says, take it up as a first line also, primary screening. If you can do with HPV, you have to have the validated test in the first order. So having a hybrid capture, I purposely bought this case because hybrid capture makes you understand the copy number. So more than one relative light unit, RLU itself is positive. Now, this is a clinically validated test, which gives you an understanding that denominator is 5,000 and above whatever comes is given as 1. So it's a ratio, relative light unit. It talks about 13 high-risk strains, but it doesn't give us genotyping. So whenever you would have done, suppose, there are various ways which our gynecologists are doing these days. What they are doing, a case comes to them, either the PS examination. Many people aren't even doing a PS examination. Bharti, do you want to talk on that? It's so important.
Oh, yes, definitely. Yeah. So initially, thank you, Dr. Priya, for having us on this excellent webinar, and the previous Dr. Girija Wag did a wonderful job. Namaste, Sundari Madam, for being here.
Namaste,
And well, I think the basic thing every gynecologist has to do, irrespective of whatever she may come, I think a speculum examination is what we have to do first, because we may be doing the HPV hybrid capture test, but that does not say that we don't do, of course, we will, if you're doing the HPV test, we are going to do a speculative examination unless it is a self-testing modality. For example, just today I had a lady, a postmenopausal woman who has got a very very confusing reports from previous gynecologist. They have done a pap smear because she went with postmenopausal bleeding. First pap smear comes as HCIL, and then the gynecologist was confused as what we've done. They have repeated it, and it has come as LCIL. Then they were referred to me for colposcopy. And so when I did the colposcopy, she was a SWADES score which was less than 3. However, there was a small endometrial, a small polyp-like tissue lesion was there. And I also did an endometrial biopsy under hysteroscopic guidance for her, and she had an endometrial polyp also. And so the bleeding probably was not from the cervix, but it was coming from the endometrial polyp.
Absolutely.
So, and they were worried because the report came as HCIL, and they said this is pre-malignant, you have to undergo a hysterectomy. So I think in such cases, we have to be very, very prudent in our clinical examination. One, two, the first history, then the clinical examination. And in, especially if they come with postmenopausal bleeding, we can't just do a HPV test or a pap smear and go with just that one report. We'll also have to do an endometrial sampling, ideally a hysteroscopic examination. So clinical examination, then do the HPV. Routinely, if they come to you, we do routine HPV testing for all women about 30 years when they come. I give them awareness, and if they're not able to do it at that sitting, they come back for the next sitting. And if the HPV hybrid capture low risk, there's no positivity, there's low risk, we ask her to come back for 5 years. But I tell her to come back next year for a speculum examination, not for a HPV test. I am going to do a speculum examination after a year for some other lesions she may get. And she may be having some other uterine abnormality, though she's normal. But if the HPV test comes positive, here is the glitch that most of our regular gynecologists are facing. What next?
Correct.
Because many
Absolutely.
are not colposcopically trained with colposcopy. So the head still comes, they will say hysterectomy. So I think this is where we have to say triaging is necessary. You do your HPV test, it comes positive, or there is a lesion and the HPV test may be negative. Please advise a colposcopy for them.
Correct. And in your case, Dr. Bharti, you just mentioned post-menopausal bleeding or spotting. So it's very, very important to understand that as per these guidelines of ASCP guidelines 2019, it had a risk stratification symptoms for doing a colposcopy. So initially in 2012 and all, we used to talk about screen positives go for colposcopy. Now we are also saying that postmenopausal bleeding, intramenstrual bleeding, postcoital bleeding, repeated white discharge. It means like 3 to 4 times she's having white discharge. And it's not getting treated. I mean, she's gone to a number of doctors. She's, in spite of taking tablets, she's not getting the relief. And unhealthy cervix.
Yes.
Even though the screen might be negative. I've seen a number of cases in my lifetime where the screens were negative, as Sundari Madam just mentioned. That could have been, or you also mentioned, like, one was HSL, one was LCIL. How do we then understand that are in the same lab, in the same thing? This is where symptoms, speculum examination, understanding the cervix truly comes into the play. And when you do a colposcopy, do a scoring. I have seen cases coming from Pan India where only photos are there. The photos are taken to go ahead doing a hysterectomy. So let's dissuade ourselves. Colposcopy is a brilliant tool, absolutely brilliant tool to understand the cervix. If you're not a colposcopist, not that everyone are colposcopists, not that everyone knows colposcopy reading, this type of high-risk cases, please refer to colposcopy is number one. We do have these days AI-based, mobile ODT, like
Mobile DT devices.
GenWorks has got his mobile ODT. So in this, the AI based is there. Now, having this type of tool in the clinic, in your facility, truly helps. I mean, you
Yes.
looking at directly and then doing a VIA, might be sometimes a shadow comes. You're missing out so many lesions if you're not proficient enough to do a VIA. Even when I say VIA, VIA also requires its own understanding. Otherwise, many times, Madam Sundari Madam is over here. She has been the doyen of screening in Karnataka. Ma'am, you will agree with me
Yes.
that many a times false VI positives.
Yeah. Yeah, many a time. It has got
So
its own
that's why-
limitations.
Its own
No,
limitations.
it's not a false VI, but you must be, as you are telling both of you, clinical examination, you have to get oriented how thick acetovoid is a thick and pathological when you do VIA, Priya. If you know that, see what happens is even in a metaplastic epithelium takes up the acetic acid to a certain extent, is it not?
That is
So many
physiological.
things. So that time you as you go on seeing it, you will understand, oh, this is pathological, this is, you will be able to discriminate that. So that
Correct.
is what we wanted. And one more thing in a Bharti's point, can I or you want to finish? Yeah.
No, ma'am. No,
Finish,
this
Priya.
is a
Yes,
open
One more
discussion.
thing
Yes,
I
ma'am.
just wanted to tell you is, please, we have to understand something is HPV DNA testing and the cytology abnormality what we get are not equal. I always teach my student HPV DNA testing means what? It is a serological test. It means she is harboring HPV DNA virus. That doesn't equal to cytological changes in the cervical cells. It may not bring also the cells. She may be, because now I have a great problem in the villages because Indian Cancer Society is associated with me in Karnataka. They are bringing only HPV DNA testing. That to COBAS, we are doing it. Every patient, every camp, when I do about 25, 30, believe me, 6 are positive HPV DNA. It's a mammoth task to bring all of them for colposcopy because I have to do either they are 16 or 18 positive. One more thing is if it is not 16, 18 positive, we can postpone our colposcopy and we can do a PAP and then we can call them back after 6 months. That's number one. If it is 16 and 18, definitely it warrants in material of our cytological report, it warrants for a colposcopy. These are few things we have to remember as a practitioners. Now, HPV DNA can be positive, but she may not become cytologically abnormal even forever. After 2 years, you repeat HPV DNA, she may be negative because it takes 1 to 2 years is a transitory period for HPV to spontaneous regression or resolution of the infection. So we may have to wait for that. So HPV DNA is positive means even 16, 18. It doesn't mean that she has to be positive cytologically. And it is proved in the villages now, many of them are HPV DNA positive, but none of them is positive colposcopically. Even sometimes because it's 16, 18, though it is so much of experience, sometimes it breaks your head. So take a small biopsy, even a very thin acetovoid, non-spicuous acetovoid also, you take a biopsy, it comes as cervicitis. So I have been going through for the last 2 years this. So please understand HPV DNA matlab, it is, she has infection, she has a potential to go through for the abnormalities or a pre-malignant lesions in the cervix. It is not equal to having a cancer or a pre-malignant lesion. That's the other thing people have to remember. Only thing it says to us is she needs a close surveillance. How close is the surveillance? If pap smear is negative, we know after 1 year we call them. And Priya was talking about ASCP risk scoring. I mean, that if you can download and keep the app with us in our mobiles, it's very useful. I tried, but I'm not able to download it. But say what it says is mainly depends on previous HPV test results and PAP results. That's all it talks about. Depending on that and the prayer, now presently, what is that? Correlate them and say, you calculate the risk for CIN 3 plus, not 2. 2 is again transitory. It can clear off. When we know CIN 1, 2, it can clear off majority of them. So CIN 3 plus risk categorization is that if their risk is more than 4%, immediately it warrants for a colposcopy, not even colposcopy, straight away some treatment they say. That is the risk scoring by the ASCCP, which has been introduced in 2021. I think they have introduced. So these things, if we remember, unnecessary colposcopes and unnecessary treatment, especially, we will not be giving to the patient. Thank you, Priya, for that.
That's exactly what, madam, we really need to give a take-home message that HPV, having an HPV, don't fear. Because HPV positive, what next makes the world collapse for the patients. The doctors really also get a lot of stressed when they see HPV positive on the report, and the patients look to the doctor to say, now what next? And because of lot of ambiguity in understanding how to go about with this, they land up into unnecessary hysterectomies. Now, the thing is, I always say this to all our candidates, even if you do a hysterectomy, HPV is going to remain onto the vagina. Are you going to remove vagina too? No. So there are methodologies of how to take it up. And HPV positive, as Sundari madam fantastically said, you are putting a genotyping if it is 16 and 18. Now understand one thing, dear friends, when we talked about SIN3, madam just mentioned SIN3 plus risk. We are more worried that the patient should not go into a cancer. CIN2 can also regress. CIN1 definitely can regress. Now, so the understanding is if it is 16 and 18, let her go for a colposcopy. If it is added with an HSIL, that means the SIN3 plus risk is above, say, 60%. So having above 60% of risk of becoming SIN3 plus, there is a methodology of doing expedite treatment. You can do a treatment, but only if, again, you should be having a good cytopathologist, giving your results of cytology also. Don't get swayed away. What is happening is there is a lot of swaying away. Otherwise, do a colposcopy, take a good punch. Another thing, if your colposcopy also has got limitations, even with the best of the best hands, Dr. Sanger used to say this, that even with the best hands, the colposcopic sensitivity is say to the tune of 80%. You might miss out. So what you do is taking a biopsy, best thing, take a biopsy, 2-quadrant biopsy can be taken up. If you're not understanding colposcopy in the best fashion, put a VIA, as madam just mentioned. VIA, you have to know the parameters. Metaplasia has got 8 different parameters by which you can understand that this need not be a lesion. Metaplasia is also VI positive. But then you understand by understanding it's a thin, it is shiny, it is translucent, doesn't have a set geographical pattern. It can just arise anywhere. And again, it appears and disappears fast. It's cloudy. It's like, it's merging with the rest of the tissues. So finger-like, fawn-like. These are the VIAs, which are the metaplasias, which are physiological. Again, I always keep on getting, even today, even now, I get a lot of messages. Madam, my this thing was metaplasia. Should I go ahead? What do I do? Please understand, dear friends, metaplasia is a physiological condition coming from single columnar epithelium to multiple squamous epithelium. So don't worry. It is just physiological. And Dr. Bharti also mentioned very clearly, post-menopausal spotting, bleeding, do an endocervical curette, do a endometrial biopsy too. So these are very important things to understand. Do not get scared because she is an HPV. Many HPVs regresses. Another thing, the other day I was with NDTV and they said there was a lot of this, with the Entagi and all that, no? So there was a nice discussion which went ahead with HPV. And the discussion was, please de-link HPV to sexuality.
Yes.
HPV can be positive with a monogamous relationship too. That doesn't mean that, having an HPV means a cancer or an HPV means polygamous relationship. No, 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 no. HPV is a very common virus. Having an HPV, we have the protocols. We had brought GCPR. FOGSI GCPR came out very well in 2023 during my time as Onco Committee Chair. If HPV is positive, you triage it with genotyping. Genotyping 1618, as Madam superbly said, 1618 do a colposcopy. Non-1618, triage it with a PAP test. If the PAP is showing NILM, you have an adequate time of 2 years. Just wait for 2 years, repeat an HPV. Superb. Or you do not have the facility for triaging, or the patient is not you can do a VIA, simple. You can do a colposcopy if you have. So this type of triaging methods are very important, friends. The purpose of doing this case-based discussions are, we don't want things to go berserk, which is happening these days. And we don't want excessive hysterectomies to occur, or not doing at all. Either we do over treatment or we actually don't see at all. And we say nothing will happen. Now, in this case, if you see, which I had brought, now this case is an HSIL. She is a CIN2. She is a PAP HSIL. And if the colposcopy reading wasn't adequate enough, it was inside, you do have to have the colposcopic view to understand this case. It was, this could be easily missed out. No problem. It could be easily missed out. So biopsy is very important. So that's what I wanted to get from this case. And Dr. Sundari, Dr. Bharti, anything else you want to tell to our viewers? Most welcome.
No, as you rightly said, Dr. Priya, I think at least a VIA. Everybody may not be a colposcopist, but a speculum examination, a VIA, and a biopsy could give us adequate information to manage them and avoid unnecessary treatment. I think that should be the take home.
Yes. The last word from Dr. Sundari, madam.
Don't treat pap smear reports. Try to have a biopsy. See, histopathology is the gold standard for planning any treatment. So pap smear has come HSIL, I'll treat the patient, no way. So we have to have a gold standard test that is a histopathology. Either you do by VIA biopsy or you do by colposcopy. But though WHO said that screen and treat and then see and treat again, we'll take a biopsy colposcopically and treat at the same time. Screen and treat is we are limiting it only to the community-based screenings where they don't come back there. Otherwise, in your practices, if your patients are in a private practice or institutional practice, when we are doing the pap smear reports, we should not treat. We must have triage, and we must have a authentic report by the histopathology. Either you do by VIA biopsy or you do by colposcopy biopsy, whatever it is, you do. And one more thing is, please don't do a blind cervical biopsy.
Yes.
It has no role. Please don't do cervical biopsy. You look at the cervix, it looks very normal. When I put a colposcope and put acetic acid, there's a huge lesion coming up. So by just a naked eye, we'll not be able to know where to take a biopsy. At least put acetic acid. You can keep a 5% acetic acid, which is nothing but a vinegar. You dilute it into 5% and keep it in your, in a OPD, put it there, wait for 1 minute, and then you take a biopsy. If not, the colposcopically directed. No blind biopsy on cervix, treatment of cervix. Any screening method you have done, don't treat except the VIA, which has been advocated by the WHO, screen and treat. Otherwise, always have the authentic report of. One more thing which is important is to have a report by HPV, histopathology report is a later to follow. If you just see and treat, you don't know what is the severity of the lesion, we don't know. We are seeing after hysterectomies also, we are seeing the wart recurrences. If the HPV is positive. So please just don't, wherever there's a possibility, take a biopsy, guided biopsy, and then properly treat them. CIN, we don't need to treat them. Now the histopathology also is being terminated. Terminology is LSIL and HSIL. If it is LSIL, you don't need to treat them, just follow them up. If they are persistently positive, then simple method of ablation can be done. If it is HSIL, then you have to know what is her chance of progressing. For that, again, a molecular test has to be done now, P16. If the P16 they are positive, yes, they are going to high-grade lesion. That CIN2, I mean, histopathologist has to give HSIL favoring CIN2 or favoring CIN3. They have to give, but still our histopathologists are not yet oriented to that. They will take time. Meanwhile, what we could do if they give us HSIL, if patient can afford, we get a P16. If it is positive, you can do ablative method there itself. Or if the lesion is big in such people, I think it's better you do colposcopy. Lesion is big and see the transformation zone, you can do excision. But if it is CIN3, always CIN3, HSIL favoring CIN3, always it's excisional procedure. Simple things we remember. CIN2, you can be ablative or excisional depending on the, again, high risk factor for her. CIN1, whatever it is, even HPV DNA positive, it is CIN1, it has come after your evaluation. Just follow her up. It will regress. Many of them it will regress because we have been seeing it for many, many decades. So that's this one, how to just go about with the simple thing. So low grade lesions, follow up, high grade lesions, treat, CIN3, excisional always, CIN2, it can be ablation or excision. That's all it is. The whole gist of it is only that much.
Yes. So thank you, madam. It was truly wonderful because this type of small case discussions truly matters for all the practicing gynecologists, and how to take it up makes a lot of difference, hell lot of difference of case management. Thank you very much. Over to Dr. Ananya. If there is any questions from
two more panelists are there, no?
Audience.
You have
Dr. Vidya couldn't join because she's having a case. Yeah, she just
couldn't join.
Yes.
There is a question in the chat box. What to do if PAP report is ascus? I think cleared it.
Okay. So like PAP is ascus, you don't have to worry. Number one is you can put up an HPV triage. And if the PAP, ascus and HPV negative, just nothing to do. Call her up after a year, repeat her PAP test. No need to even repeat an HPV. But if the PAP is ascus and HPV is positive, then you have to go for a colposcopy. So that's the simple understanding with PAP ascus. Ascus means atypical squamous cell of undetermined significance. That's the main thing. Only if the PAP is LCL and above directly, you can go in for a colposcopy. If you are colposcopy based, cytology based screening person, as many of the doctors in our country are still cytology based screening. So this is how you can take it up. Yes.
I think we can conclude this session. Thank you, experts, for such an enthusiastic and comprehensive discussion. And we can move to the vote of thanks now.
Thank you.
Before that, thank you, Priya, for involving me into this wonderful webinar. I enjoyed it. Thank you.
Thank you very much, ma'am. Yes.
Yeah. Thank you very much, doctors. And we have had some excellent discussions so far. To wrap up the session, I would now invite Mr. Abin, Product Manager, GenWorks, to share the vote of thanks. Over to you, Abin.
Thank you, Rashmi. A very good evening, all. Okay. A very good evening to all. Today's section was truly insightful, filled with an evidence-based insights, case discussions, and clinical outcomes that contribute to strengthening the clinical practices and improving the patient care. On behalf of GenWorks Health and the organizing committee, I would like to extend my heartfelt gratitude to all our distinguished speakers, panelists, and participants who made this CRUSADERS Women's Health webinar a grand success. Thank you all. And first of all, I would like to thank you, Dr. Ananya, for conducting this section seamlessly. Your excellent moderation and coordination ensured that the section remained engaging and informative throughout. Thank you so much, Dr. Ananya. A special note of appreciation to Dr. Priya Ganeshkumar, who has been the guiding force and the brain behind the entire webinar initiative. Our heartfelt thanks to our guest of honor, Dr. Revati Janagi Raman, for gracing the occasion and blessing us as we embarked on this very first section of the series. I would also like to thank Dr. Girija for her insightful presentation on fetal monitoring, along with our esteemed panelists, Dr. Chandrakala Maran, Dr. Rekha, Dr. Ramaraju, Dr. Aruna, Dr. Amala Devi, Dr. Umayal, Dr. Sambat Kumari, Dr. Vijitra, and Dr. Prashanti for their valuable inputs that added immense value to today's discussion. A special mention to Dr. Priya Ganesh ma'am for leading us an excellent and insightful case discussion, and to Dr. Bharti ma'am, Dr. Sundari, Dr. Vidya for their commendable contribution that added a great value to the section. We extend our heartfelt appreciation to all the participants for their active engagement and enthusiasm throughout the section. Lastly, a big thank you to our wonderful GenWorks team for the seamless coordination, dedication, and the tireless efforts behind the scenes. Your enthusiasm and excellence made this event very possible. Thank you all once again for being a part of today's webinar and making it a meaningful learning experience. Thank you all.
So, Rashmi, you can show the slide of what is going to happen in the next series.
Yes. Thank you, Abin. Let's stay connected with GenWorks Health as we continue to bring impactful educational programs that empower clinicians and promote better healthcare outcomes. We look forward to seeing you again on November 20th for another exciting session. Dr. Kiran as our guest of honor and an expert panel by the biggest minds of India, none other than Dr. Muralidhar Pai and Dr. Priya Ganeshkumar with her experts will be discussing a wonderful case on sin management. Thank you again, everyone, for being part of CWH Crusaders Women's Health Webinar and for your commitment to advancing women's healthcare.
See you next 20th. 20th, you're going to come up with another beautiful, wonderful reverse panel discussion on adolescent PCOS. So topic would be great, and see you all. And Dr. Ananya, thank you very much. And thank you very much all the faculties and the audience to make this a great day. Thank you, GenWorks, for your input. Thank you very much.
Thank you. Thank you.